Start, right? Can you hear me? Can you hear me? Okay. Good afternoon, everybody. So we'll talk about mood stabilizers. I think previous lecture covered a little bit about antidepressants that deals mostly with the depression, but mood stabilizers deals with both mania and the depressive phase. That is a bipolar disorder. And I like this slide showing manic phase, which may last weeks or months, where the person is overly active doing things, whereas in contrary, in the depressive phase, person tries to sleep or lethargic or don't do anything for weeks or months. So it typically represents the topic. That's why I like this slide. So in this mood disorders, I mean, mainly the bipolar disorder is the one which we'll discuss. I think you already heard some introduction, but I briefly glanced through some of the symptoms, incidents, and what are the different types. But mainly, the pharmacotherapy is the one which I will spend significant amount of time dealing with what are the different types of drugs that are involved in treating this condition, both in the manic phase and depression phase, both acutely as well as in the maintenance. And then definitely got to know the list of the drugs and where you give it, and then briefly some mechanism of action and pharmacokinetics, some here and there, and then some drug interactions, but definitely adverse effects. You see a lot of adverse effects with these drugs. So you may want to know about these things because you want to know when the liver fails, or also when the liver fails or heart fails or other organ fails, what type of drug you got to use in that specific patient. So bipolar disorder is basically a period of mania, depression, mixed state, and hypomania, interspersed with periods of relative wellness. So in a normal person, you always have these kind of situations. You feel excited, at the same time you get depressed, but only for a short period of time. But a person with a bipolar disorder, these things actually occurs in cycles that go on for months. That's the reason why this is a disorder. This is a disease condition. So the main symptoms of the mania, you can easily remember as a dig fast, which is a distractibility, insomnia, grandiosity, flight of ideas, agitation, sexual indiscretions, and talking, pressurized speech. And some symptoms of depression, intense sadness or loss of interest for 2 or more weeks, fatigue, insomnia, psychomotor agitation or retardation, weight gain, either gain or loss, cognitive dysfunction, feeling less of worthiness. So basically depression is opposite of what mania. And mixed state, you have depressed mood combined with increased energy, both manic and depression state combined for the varied period of time. And during this mixed state, there is the highest rate of suicidal ideation or attempts have been shown in this mixed state. And another state is the hypomania, which is a less severe form of mania. So in this state, a person may feel very good, be highly productive, and function well, but may not feel that anything is wrong. But others can see that there is significant mood swings or changes in the activity levels. So without this proper treatment, person can get into a state of a full-blown bipolar disorder if this hypomania is not addressed at the right time. And here you can see showing manic phase, extreme conditions like both manic phase and depressed phase is a smiling phase and the crying phase. And manic phase, you have high energy, higher self-esteem, racing thoughts, very quick talking, impulsive behavior, irritability. In the depressed phase, you have lack of concentration, low self-esteem, suicidal thoughts, helplessness, loss of interest, and low energy levels. So it's bipolar disorder basically two extreme conditions. One is excited, very excited. One is low time. So, but these two situations are occurred for a very period of time that can prolong for months. So there are different subtypes. So they're basically bipolar 1 disorder, where there is a manic or mixed episode with or without psychosis or major depression. Bipolar 2 disorder, hypomanic episode with major depression, no history of manic or mixed episode. There is a cyclothymia disorder, hypomania and depressive symptoms that do not meet criteria for bipolar 2 disorder. And bipolar disorder not otherwise specified, does not meet criteria for major depression, bipolar 1 or 2 disorders, or cyclothymia. So kind of summary showing duration, how long these states will. In bipolar 1, you have manic episodes that last at least 1 week, and depression also lasts at least 2 weeks. Maybe mixed episodes possible, no hypomanic episodes. Bipolar 2, you see depression episode and hypomanic episode, but not manic or mixed episode. Cyclothymia disorder, you see depression episodes and hypomanic episodes that can last for more than 1 to 2 years. And bipolar disorder not otherwise specified, you may see manic episodes less than 1 week. And it has been shown that this condition is seen more prevalent in younger people, less than 25 years. And it is mostly diagnosed during adolescence or early adulthood. And somehow it is more seen in patients who are well established or well upper socioeconomic class people. And it is also mostly most of the heritable disorders compared to other diseases. And also environmental factors like abuse, mental stress, or significant loss of a relative or parents or other person loss can trigger this disorder, and some other traumatic event. And some hormonal problems like hypothyroidism, changes in the fluctuations in those hormones can trigger this bipolar disorder. And suicide rates is very high in this condition, around 20 times higher in patients with bipolar disorder than in the general population. And 1/3 of patients with bipolar disorders attempt suicide, a rate that is among the highest of any psychiatric diagnosis. So this condition needs to be addressed. And there is every chance that bipolar disorder can be easily confused with other psychotic conditions. So other psychotic illnesses, basically psychosis is this is a normal way, it's not normal way of thinking. So these people will be have hallucinations or delusions or abnormal way of thinking. So those conditions or psychotic conditions include schizophrenia, manic phase of bipolar disorder, OCDs, obsessive compulsive disorders, schizoaffective disorders, and psychosis induced by Alzheimer's disease or Parkinson's disease, or substance-induced psychosis. Some CNS stimulants can induce these psychotic conditions. So you see bipolar disorder patient with the psychotic conditions. How do you identify them? So sometimes a person with severe episodes of mania or depression also has psychotic symptoms such as hallucinations or delusions. The psychotic symptoms tend to match the person's extreme mood. For example, someone having psychotic symptoms during a manic episode may believe she or he is famous, has a lot of money, or has special powers. And if someone having psychotic symptoms during a depressive episode may believe he is ruined or penniless or that he has committed a crime. So as a result, people with bipolar disorder who also have psychotic symptoms are sometimes with misdiagnosed schizophrenia. So basically you have these kind of positive and negative signs of schizophrenia. And some of the drugs that you use, they also overlap with the they're also used for schizophrenic condition. So we'll discuss those drugs also. So there are different ways of treating bipolar disorder. So electroconvulsive therapy is there, pharmacotherapy is there, other treatments there. But in this lecture, we deal with pharmacotherapy. What are the drugs that we use and mechanism of action, adverse effects, all that things. So in a clinical scenario, how do you manage these patients? So you manage both acutely and chronically. So you treat for acute episodes and maintenance episodes. Maintenance therapy. So acute bipolar episodes usually demand immediate symptom containment. So maybe you see this kind of patients in the emergency department. So you have to treat this. So you need to know what type of drugs you need to use in that situation. And some drugs which are used in the maintenance phase, they're not useful in the acute phase. So vice versa. If they're good in the acute phase, they're not good in the maintenance phase. So which one you want to know? After the resolution of the depressive or manic episodes, the maintenance treatment phase is aimed at prevention of future episodes. Maintenance phase is mainly to prevent the recurrence of the disorder. So what are the drugs that are mainly used? So lithium is a very well-known, standard and very well used drug and efficient drug. Only problem with the lithium is it has very therapeutic index. That means the dosage control is very, very tough with lithium. That's the reason why nowadays a lot of clinicians, they go with other drugs. So other drugs include anti-seizure drugs. We'll discuss in this anti-seizure lecture also these things, which include divalproex or valproic acid, I combine this into valproic acid, and we'll discuss in detail about that. And lamotrigine, carbamazepine, and some lorazepam in the benzodiazepine group, they use it in this bipolar disorder. And some of the atypical antipsychotics, they're very widely used, and they're also misused. We'll see how they misuse it. And they include aripiprazole, olanzapine, quetiapine, risperidone, ziprasidone, and also typical antipsychotics like haloperidol, which is used as in the acute conditions. So we'll discuss about these drugs in antipsychotic lectures also. We'll again come back and look at it in a different perspective, these drugs. So lithium is a gold standard of mood stabilizer. It is a small monovalent cation, and it is available for oral administration. And it is also used as for long-term treatment, but also used in the acute. So it is especially effective for manic phase, and 80% effective in acute mania or hypomanic episodes. Once you start the dose, even for the acute condition, it takes a time like 5 to 10 day latency for the response to see. But most of the time, you get the response. So that's the confidence that is achieved with the lithium. So you see the change in the patient. And 60% effective long-term maintenance definitely decreases the number of episodes and their intensity, and does not benefit patients with mixed states or those who have rapid cycling. So who have a recurrence or a mixed state, this lithium may not be useful. And it also reduces suicidal ideation more than other treatments. So because of the long latency, so sometimes it takes 5 to 10 day time is significant amount of time. So nowadays, this drug, lithium, is replaced because of that condition. So because of the delayed latency of response, nowadays, valproate and other antipsychotic drugs like aripiprazole, Abilify, those are being used in the clinical situation. How do the lithium works? So basically, lithium will interfere in the lipid recycling. So majority of the neurotransmitter released in the brain or in other places, they act to G protein coupled receptors like epinephrine, serotonin, norepinephrine, you name it. All those things, dopamine. So they all activate the G protein coupled receptors, and invariably they all activate secondary messenger pathways through IP3, inositol triphosphate, which is a glyceride, phospholipid, and then diacylglycerol. So they all activate secondary messenger pathways that will have significant effects on the cell through overall body. So now lithium will interfere in this IP3 pathway. So they inhibits the recycling of this one. So maybe overactivation by those chemicals will be inhibited. So you may have relief in the disorder. And it has a very, very long half-life, 20 hours, and it takes it changes with the age. So in the elderly, it goes up to 36 hours. So once you give the drug, it stays for a long time. And I told you that it is a very narrow therapeutic index. So these patients are, they're not thinking right. They have either too much depression or too much maniac. So somebody has to take care of them. So if you send this drug on a chronic basis for them to take, so maybe they may not follow the clinician's guidance. So they may not take this drug. So in that condition, because of this narrow therapeutic index, slight changes in the dosage can lead to toxic conditions. And there are a lot of side effects also with this drug. So that's the reason why, because of this narrow therapeutic index, lithium is nowadays less used in the chronic use. And 99% of the time, lithium is excreted in the urine. So it is excreted in the urine. And there are a lot of drugs that can influence the changes in the levels of this drug through acting in the clearance. So some drugs may reduce the clearance, so causing to lithium toxicity. Some drugs increases clearance, so low dose of lithium decreases the lithium levels. So for us, if we want to remember easily, because this is, I think, very, very important to know, because a lot of people take these drugs, and most of the times your questions are framed, this patient is taking this drug, how does this lithium will work, whether it's going to be toxic or like that. So for easy to remember, so most of the time we drink coffee or tea. So they have xanthine preparations. So whenever we drink coffee or tea, we tend to go to restroom for urination. a lot of times. So when you have a lot of urine output, so obviously there is a more clearance, so you have less lithium in the body, so overall decreasing the therapeutic levels of lithium. So other drugs could be acetazolamide, like diuretics, and alkalizing agents can also do the same. So on the other side, diuretics, NSAIDs, metronidazole, and ACE inhibitors, they increase the lithium levels, contributing to lithium toxicity. A lot of people take these drugs for hypertension or for other conditions. So they can change the lithium, increase the toxicity. So you may want to know what type of drugs they can changes the pharmacokinetics of lithium. So because of the low therapeutic index, and some people take this drug excess than what they needed, or by accident they take more, so it can lead to toxic doses. So a lot of side effects you see with this one. So tremor is one of the common side effects that you see with the lithium. And when you see this kind of conditions, beta blockers such as propranolol or atenolol will alleviate that condition. And kidney-related problems like polydipsia, polyuria is seen, and sometimes edema is seen. So you got to avoid in patients who have severe renal disease, because most of the times it's excreted through urine, through kidney. So if there is a problem with the kidney, like aged people, so there is a more toxic levels in the body. And also you avoid in the patients with the cardiac problems, like it can depress the heart SA node. So people who have sick sinus syndrome or acute MI, so you avoid lithium. And also it is avoided in pregnancy because it can induce abstinence abnormality, which is a cardiac abnormality in the babies. And it can also change the thyroid levels by inducing either hypothyroidism or goiter. And it also transmits through the nursing, through the milk in the nursing mothers. So the lithium is contraindicated in nursing mothers. And toxicity, most of the times, toxicity can be avoided by decreasing the dose or stopping the dose, or if the dose exceeds too much, hemodialysis is the only another option. And moving on to the next type of drug is the anti-seizure drugs. We have valproic acid in this one. So valproic acid or Depocaid, it is the first choice for the treatment of acute mania in USA. I mean, after lithium or lithium non-responders. And also it is used in focal and primary generalized epilepsies. So it appears to be more effective than lithium for mixed states. The way valproic acid induces its effects, at least in seizures, or maybe it could be doing the same thing in acute mania, but it is very well known to inhibit sodium channels, calcium channels, and increase the concentration of GABA, and also increase the potassium channel activity. All those things may decrease the seizure activity, but at the same time, it could be affecting the acute manic pathological conditions. And it inhibits CYP enzymes. So whenever these drugs are taken, when the CYP enzymes are blocked or inhibited, it could change the concentration of other drugs. So like if they're taken like carbamazepine, lamotrigine, phenobarbital, and phenytoin, and people do take these drugs along with the valproic acid, especially in the acute manic phase, because combined treatment is one of the suggestion elevated by the clinicians, saying that you got to give one or two drugs. So when you have the combination, if one drug interferes with the CYP metabolism, there is every chance the concentration of other drug goes up or down. So in this case, valproic acid inhibits CYP enzymes. So if the carbamazepine is taken, so carbamazepine goes up, and you have all the side effects associated with the carbamazepine. So you need to know these drug-drug interactions with the valproic acid. And side effects may include somnolence, nausea, dizziness, and hepatic damage. So a patient who has liver problems, valproic acid is not given. With the bipolar disorder, liver. Yeah. Yes, they inhibit the CYP450. So this is the question that's been seen a lot of times. So a patient who has renal problems, which drug we should not give? Lithium. Because therapeutic levels are, it has very narrow therapeutic index. If the kidney cannot clear it, so you have toxic levels. So if the patient has liver problems, what drug you should not give? Valproic acid. Because, so valproic acid can make it worse. So those are the kind of questions you may expect in the boards. And so you have to monitor liver function test, platelets and ammonia levels. And it should be avoided in pregnancy because of the teratogenicity associated with valproic acid. So you see neural tube defects like spina bifida. So this is a normal anatomy of the baby where the normal spine, and you have, this is a chalatomorphin, it's a spina bifida. So usually this condition can be alleviated by supplementation of folic acid. So another drug is the lamotrigine or lamictal. This is also anti-seizure drug, and it is approved for maintenance treatment of bipolar disorder and particularly effective in bipolar depression. So the way it acts is it blocks the sodium channels and calcium channels. And chronic use, it can cause Stevens-Johnson syndrome, which is a rash-like symptoms, fever, joint pain, all that stuff. And this is acceptable in pregnancy. Not much of teratogenicity, but again, some people have shown this. There is this is a good acceptable agent in pregnancy, not valproic acid. And it is associated with weight loss in obese patients with bipolar I disorder. So co-administration with Depakote may increase lamictal levels, and titration must be performed more slowly. So it's again associated with the drug-drug interactions. So this is the typical Stevens-Johnson syndrome. So 10% of patients can have this rash, and FDA has black box warning on this drug. So mild rash, moderate rash, and severe rash. Mild rash have hives, itching, and swelling. Moderate rash, you have fever, joint pain, muscle pain, general discomfort, swelling of lymph nodes, and high eosinophils. And severe rash, you have necrolysis. This is a toxic epidermal necrolysis, maybe peeling off the epithelial layer. You see blisters or sepsis, and can even lead to multiple organ failure. Another drug, anti-seizure drug, is the carbamazepine, also called Tegretol. So it is used for acute mania and maintenance therapy. And it is not FDA approved, but still some people use it. And it blocks sodium channels, voltage-gated sodium channels. So by blocking voltage-gated sodium channels, it inhibits the generation of repetitive action potentials. So that could prevent the propagation of the pain signals or propagation of the signal associated with the acute manic phase. So this is a primary drug for focal and tonic-clonic seizures. So based on this mechanism, they inhibit the seizure conditions. Evidence for carbamazepine is not as strong as that for lithium and valproate. So this is the second or third drug of choice after lithium or valproate for bipolar disorder. And common side effects include somnolence, dizziness, nausea and vomiting, and mild ataxia. So you can avoid these drugs by reducing the doses or titrate the dose slowly. And sometimes, like one in a million or 6 in a million, you see agranulocytus or leukopenia. And sometimes you may see hyponatremia in elderly patients, especially the cardiac condition. And it can also, carbamazepine, just like valproic acid, can induce neural tube defects causing spina bifida. So it is not used in pregnant women. And another drug is lorazepam or ativaven. It is a benzodiazepine, and it is used as combination therapy in patients with acute mania to reduce agitation. And it is not effective in maintenance. And primarily, this drug is used in seizures, generalized tonic seizures. And it is available oral route, IV, and other routes. And it decreases the seizure mechanism is increases chloride conductance to GABA channel. So that's how it reduces the seizure activity. But it is not known whether the same mechanism is involved in the acute mania. And because it does that, so there is no strong study suggesting that. But definitely seizures, people show that benzodiazepines increase the GABA channel activity, decrease the seizure. But since we know the mechanism, maybe this could be the mechanism in acute manic episode. And there is a wide variability in the absorption. Half-life is around 2 days, and lipid solubility, it can be sequestered in tissue, and many metabolites are active, and it variable impact on hepatic microsomal enzymes. And major side effect that you see with benzodiazepines is respiratory depression acutely, and some confusion attacks sedation. But in chronically you see dependence. So this is a problem with addiction. So, and maybe significant abuse liability, some other changes, but not of significant. And another group of drugs that are used in bipolar disorder is antipsychotics. So there are atypical antipsychotics and typical antipsychotics. We'll go with this one, each one. So aripiprazole is one of the very widely used agent for bipolar disorder, and it is effective for treating acute and recurrent mania. So especially irritability and agitation and mixed episodes. So maybe in the acute emergent situation, aripiprazole could be useful to decrease the manic phase, but not effective in acute and recurrent bipolar depressive phase. So it is mostly useful in the manic condition. And it is also not FDA approved for treating bipolar depression. And not to be used to treat older adult patients who have dementia, maybe it could lead to death of the patient. And pharmacokinetics, the linear pharmacokinetics, so as you increase the dose, blood concentration will keep increasing. And half-life is long, so 75 hours, and it is again metabolized with CYP enzymes. And broke down product dihydroaripiprazole is the active metabolite of the drug, and even it has longer half-life, so 96 hours. So, but it does not have much of the CYP enzyme activity. Even though it is broken down by CYP enzymes, it does not inhibit or induce CYP enzymes. So drug-drug interaction with this drug is less. And the main side effects with any of the typical or typical atypical antipsychotics is having mild extrapyramidal effects. Those are called tardive dyskinesia. So what is tardive dyskinesia? So this is a syndrome of abnormal involuntary movements, typically involving the face, like grimacing, tongue, within breathing movements and protrusion, and lips, including lip smacking, but which can involve the trunk and extremes as well. So we'll discuss this thing more clearly in antipsychotic lectures. So basically, similar to Parkinson, but extreme end of the Parkinson syndrome. You see rigidity or face, tongue, all those things will keep moving, tremors. And there is no significant negative effect on serum cholesterol, triglyceride, glucose. And because of it does not affect any of the liver enzymes or stuff, and it does not change the glucose levels, because most of the antipsychotic drugs, not only they have this extrapyramidal syndrome, but they also influence the metabolic abnormalities. So sometimes some of the drugs like olanzapine, which comes under this group, they induce obesity. They change the metabolic parameters, and sometimes they even induce diabetes. So this drug is the one which has minimal those side effects. That's the reason why aripiprazole is preferred agent in patients with metabolic abnormalities and if they are intolerant to other psychotics. And in the old age homes, this is a very well-known fact. I mean, at least now it's a control. I think 10 years back, it was around 25% of the patients in the old age homes, they were given these drugs, like these antipsychotic drugs, which are used for during especially manic phase. So they used it as a chemical restraint on the old people, so to control them. But it increases 100% more mortality in those patients. So they now, because of the FDA-induced changes, now it came down to 16%. But still, there is not much options for the geriatric patients. So they still use these things like haloperidol or aripiprazole. It's kind of misused, but there are no options. So it can enhances the death of those patients. So another drug is the olanzapine. So it is used mainly in the schizophrenia. And also it is used in depressive symptoms. So probably people having psychotic condition as well as the bipolar disorder, especially the depressive signs, olanzapine could be useful. So this is FDA approved combination of this olanzapine along with the fluoxetine, which is antidepressant for depression and for maintenance phase. And also it can be used in acute agitation. So even in ER usage, emergency room situation with bipolar schizophrenia. It can be used as monotherapy or combination and little bit pricey. And this is well absorbed from the GI tract and by intramuscular route. Peak levels reach within 15 to 45 minutes and metabolized principally by the liver. Half-life is 20 to 54 hours and it can be used in pregnant women. So it does not have teratogenic effects. And common side effects is weight gain, that is obesity. Olanzapine can cause obesity. So there's a very high risk. So sedation, akathisia could be seen, hypotension, dry mouth and constipation. And so because of this obesity or that itself could cause metabolic syndrome, diabetogenic action. And again, this drug is again misused in old age homes, which is as chemical restraint. And this is a study showing effect of these antipsychotics, atypical antipsychotics that can change the body weight. So that ziprasidone, aripiprazole, quetiapine, risperidone, olanzapine. So you see, olanzapine is the one which increases the weight significantly compared to other atypical antipsychotic drugs. And another drug which is used is the quetiapine, also called Seroquel, and it is FDA approved for bipolar depression as a monotherapy agent, and also in treatment-resistant major depressive disorder, especially elderly and adults, and it's also given in schizophrenia. And it has no clinical significance on the dopamine receptors. It's not much important. And consider the antipsychotic drug of choice in patients with dementia associated with Parkinson's disease. So anybody who has dementia with the Parkinson's disease, especially in the elderly patients, this is the antipsychotic drug of choice. And so if they have bipolar disorder, bipolar depression, this drug is the choice for them in these conditions. So patients are highly responsive to quetiapine after 1 week of use. And then just like any other drugs, the side effects include weight gain and tardive dyskinesia, some sedation, orthostatic hypotension, akathisia, dry mouth. And one of the well-known problem with this drug is the torsades de pointes, which is a prolonged QT interval. So it can even induce sudden death, the cardiac arrest. So advantage is low risk of EPS, extravagant sun dose. So that is one of the use. I mean, even the tardive dyskinesia is one of the signs, but it is a less compared to other drugs. And the disadvantage sedation, hypotension, and again, it is misused. So you may want to monitor all the other parameters. Another drug is the risperidone or risperidol. And it is also again atypical antipsychotic drug which is in schizophrenia as well as the bipolar disorder, and it is used alone or combined with other drugs. And again, this drug is misused. And most common side effects you see is the mild sedation, hypotension, akathisia. But very well known side effect is the prolactin elevation, which could contribute to gynecomastia, amenorrhea, galactorrhea syndrome, and infertility. So you have a picture here showing the levels of prolactin after injection of this drug for measured for 24 hours with clozapine, olanzapine, risperidone, and combined drug-free patients. You can see after risperidone, prolactin levels significantly increased compared to other drugs. And ziprasidone is another drug, also geodone, is a FDA-approved drug for bipolar disorder as well as the schizophrenia. And pharmacology is well observed from the GA and IM route. Peak levels reach within 60 minutes, and half-life is 2 to 5 hours, metabolized by the liver. And common side effects, mild sedation, nausea, weakness, nasal congestion, and mild QT prolongation. So it can cause QT prolongation just like other drugs. So QT prolongation, you see this is a normal QT interval and this is a prolonged QT interval. So when the prolonged QT interval, it can cause torsades de pointes, which is a fatal arrhythmia that can lead to cardiac arrest. So there may be less weight gain, less changes in the lipid metabolism, lipid profile, unlike olanzapine. So it could be useful in those patients who have metabolic problems. And again, this drug could be misused in the old age homes. Haloperidol is a very old drug which is used as an antipsychotic drug used for schizophrenia. And again, nowadays they can be used even for acutely agitated psychotic patients. So in the acute ER setting, they just give 1 milligram haloperidol, or even old age homes, people use 1 milligram haloperidol that make the patient calm and they sleep peacefully. But again, it has its own side effects. So schizophrenia, manic episodes of bipolar disorder, this is beneficial, but it is not effective in maintenance therapy. And it has strong central anti-dopaminergic activity, but this anti-dopaminergic activity is known to induce antipsychotic effect or schizophrenia, but not sure about manic episodes of bipolar disorder. And it has weak anticholinergic and anti-alpha-nergic.
So it can be used in pregnant women. So it's an added advantage with this drug. And it can be misused in old age homes. And it is well absorbed from the GI tract and by the intramuscular route. So peak levels reach within 30 to 40 minutes of the intramuscular injection, metabolized by liver, and half-life is around 12 to 24 hours. One of the very well-known side effects associated with haloperidol or typical antipsychotic drugs is the tardive dyskinesia or movement disorders, characterized by dystonia, tremors, and also neuroleptic syndrome. And maybe in the patients who have all these seizures, this is not a good drug because it will reduce the seizure threshold in those patients. So I have some questions and summary. We are done with the lecture. So adverse effects of lithium include all of the following except A, tremors, B, polyuria, C, sedation, D, tardive kinesia. A, B, C, D. It's a tardive dyskinesia. So lithium, you do not see much of tardive dyskinesia. You definitely see tremors. So that's how people use beta blockers. And some sedation and definitely kidney problems, polydipsia, polyuria. Tardive dyskinesia is the main problem with the antipsychotic drugs, haloperidol. We'll discuss thoroughly that in the antipsychotic lecture. A 30-year-old female is brought to the emergency department by her husband after refusing to sleep for a week and spending the couple's entire savings account on a collection of fur coats. In the emergency department, the patient refuses physical examination and insists that she wear a black sequin dress rather than a hospital gown. For several hours, the patient is overcome by fits of laughter and refuses to answer questions. She then insists that she be allowed to leave the hospital immediately. Urine toxicology is negative. So which class of drugs should be administered? So this is the emergency department. So acutely, what type of drug this patient can suffer? This patient would be useful. SSRIs, B, SNRIs, C, benzodiazepine, D, antipsychotic. A, B, C, D. So I would say it's antipsychotic. In the acute situation, I'm not sure about the benzodiazepines, not much, because of a very side effect like respiratory depression. So we don't want to go with the benzodiazepines in the acute situation. But antipsychotic, I put this antipsychotic because you can choose any drug in the antipsychotic drugs. A lot of drugs qualify for that situation, including haloperidol. So this patient represents with agitation and signs of acute mania. Initial management calls for treatment with an antipsychotic. A manic episode is defined as a period of 7 or more days of elated or irritable mood, where the mood is not caused by drugs or medication or medical illness, or for example, hyperthyroidism. So, and is causing obvious difficulties at work or in social relationships and activities, or be requires admission to hospital to protect the person others. The person is suffering psychosis. Antipsychotics such as haloperidol are acute in onset and are the agent of choice in initial management of extreme agitation due to mania. SSRIs, SNRIs are used to treat depression. They may worsen episodes of acute mania. Benzodiazepines can be used as adjunct therapy to aid with insomnia and agitation, but are not first-line agents when treating an acute manic episode. So, yeah, if you spend $100 to $500, that's fine, or maybe $1,000. If you use a whole lot of money, then you got to, it's suspicious, right? Like $10,000. So definitely there is something not right. So, and if it happens over a period of time, multiple times, combined with other behavioral problems, then you consider that this is not a normal situation. So I know psychiatric is the most complicated branch to diagnose because too many things overlap. There's subtle differences, but you got to go by something, by some point, and you got to hold on to that. So in this case, anything that lasts more than a week and extreme situations hyperactive, so too much spending, and she doesn't want to listen to doctor, so and she cannot be hold, so maybe you want to treat with the calming agent. So a 22-year-old woman is brought to the ER by her roommate after bizarre behavior for the last week. She has been suffering from insomnia, grandiosity, irritability, and racing thoughts. Her past medical history is unknown. Which of the following lab values would be a contraindication to starting lithium for long-term maintenance therapy? Elevated AST, hypertension, elevated creatinine, elevated serum glucose. A, B, C, D. Yeah. Kidney problems? No lithium. So the patient in the vignette most likely suffers from bipolar disorder, which can be treated with a mood stabilizing agent such as lithium. Lithium treatment should not be studied in patients with evidence of renal insufficiency. Lithium is the only mood stabilizer shown to decrease suicidality, but must be managed appropriately. Every patient should have a basic metabolic panel prior to starting lithium therapy to assess baseline blood urea nitrogen and serum creatinine levels. Any reduced renal function may result in increased serum lithium levels and could precipitate toxicity. After commencing lithium therapy, serum levels should be routinely monitored due to lithium's narrow therapeutic index. Drugs that reduce the renal clearance of lithium include all of the following except. So, drugs that reduce the clearance means they increase the toxicity of the lithium. A, ibuprofen, diuretics, chlorothiazide, theophylline. Only one drug that increases the clearance, so less theophylline. Less drug. A, B, C, D. So it's an except. It's a negative question. So renal clearance of lithium is reduced by diuretics, NSAIDs, metronidazole, and ACE inhibitors. Clearance can be increased by acetazolamide, urea, xanthine preparation, caffeine, and alkalizing agents. Which one of the following drugs is not effective for maintenance therapy in bipolar disorders? Not effective. A, haloperidol, B, lamotrigine, C, lithium, D, quetiapine, E, valproic acid. Maintenance therapy, it is not useful. How many? A, B, C, D, E. So haloperidol, it's mostly for the acute manic patients. So not for the maintenance. Definitely lithium is used long term. So lithium, valproate, lamotrigine, and some antipsychotics, including quetiapine, are effective treatments for both acute depression and maintenance therapy of bipolar disorders. Haloperidol is an effective treatment for acute mania in bipolar disorder, but not for maintenance therapy or acute depression. So in summary, during the acute mania, the primary goal is initially include adequate sleep and reduction of psychotic symptoms. So combination therapy with lithium or valproate plus an antipsychotic is superior to either agent alone. Acute depression. During acute depression, assess for suicidal or homicidal ideation. Lithium, valproate, lamotrigine but needs minimum 6 weeks titration. Quetiapine but has extrapyramidal effects and weight gain. Patients who are resistant treatment should receive a selective serotonin reuptake inhibitor or bupropion. During the mixed states, lithium does not benefit patients' mixed states. Valproic acid is the most common used in the mixed state, and it can be titrated quickly and has been shown to be effective in mixed states. Maintenance therapy, lithium, lamotrigine, valproate, quetiapine, and olanzapine for maintenance therapy in patients with bipolar disorders. Quetiapine combined with lithium or valproate is more effective than lithium or valproate alone. Omega-3 fatty acids have a low risk of adverse effects that can help reduce depressive symptoms in patients with bipolar disorders. So in the typical drug list, we don't have these omega-3 fatty acids, but I found that these things are less side effects, so they can be used, they can be advised to take more these omega-3 fatty acids. Thank you. Please let me know if you have any questions.